Let's say you have a patient who comes in and has severe burns on a large part of their body. By large, I mean anything more than 15 to 20%. The response that they're going to have to that is known as a hypermetabolic response, which is increased body temperature, hypertension, tachycardia, and hyperglycemia. This is also followed by catabolism, protein and lipid catabolism, and lean muscle wasting. One of the things that you can do to support this person in this process and kind of cool down that hypermetabolic response in terms of the catabolism is give them a synthetic testosterone known as oxandrolone. What this is going to do is this is going to enhance protein synthesis and decrease protein catabolism in skeletal myocytes. This will help them decrease the length of the hospital stay and get better faster. A patient with transverse myelitis may also have dull back pain. So don't let this throw you off and make you think that there's some sort of compressive process such as a herniated disc. And realize that in the history there is usually going to be some sort of recent infection, either upper respiratory infection, gastroenteritis, or something of that sort. And remember that in transverse myelitis, there's a very specific level at which the sensory and weakness begin. A herniated intervertebral disc usually has a history of some sort of strenuous activity. Endometriosis can implant almost anywhere in the pelvis or abdomen. So don't always expect very, obvious presentation of it. Sometimes somebody can just come in with dyspareunia, and specifically if they describe it as deep dyspareunia, pain deep in the pelvis upon penetration. When you do a physical, it may be mostly negative, but there could be a small amount of tenderness on bimanual examination or any kind of manipulation of the uterus. Like I said, the implantation could be anywhere. If you do suspect endometriosis, you don't need a tissue diagnosis to start treatment. You don't need biopsy to start treatment. First line treatment is going to be NSAIDs and combined oral contraceptives. The oral contraceptives decrease the pain and inflammation associated with the shedding of the endometrial tissue. Other pharmacotherapy includes progestin only, such as medroxyprogesterone acetate, gonadotropin-releasing hormone analogs, such as leuprolide, or synthetic androgens, such as danazol. If you really need surgical treatment, the definitive treatment would be hysterectomy or bilateral salpingo-oophorectomy. But hopefully it doesn't get to that point, because that is pretty fucking extreme. Sarcoidosis can involve the liver in 50 to 65% of patients with sarcoidosis. When it does involve the liver, you're going to have elevations of ALK Phos and GGT. The GGT is what shows you that this is a liver issue and not a bone issue. Other things that you'll see are things typical of sarcoidosis itself, such as hilar adenopathy on chest x-ray and hypercalcemia, even if it's mild. Other non-specific symptoms: weight loss, initial treatment will be systemic glucocorticoids such as prednisone, and it is advisable to do a biopsy to rule out other possible granulomatous diseases. Sarcoidosis is one of several granulomatous diseases. When it comes to pregnancy termination, you have several options. Pharmacological options, you have 3 of them. You have methotrexate, mifepristone, and misoprostol. Now, let's look at what each one of these medications does and what the indications are for each of them. Methotrexate is used for ectopic pregnancies. It's a folic acid antagonist, which means it inhibits dihydrofolate reductase, which means it stops DNA synthesis. Essentially stops the growing of the fetus completely. Mifepristone and misoprostol. Mifepristone is a progesterone agonist. But during pregnancy, it acts as a progesterone antagonist because it competes with the natural progesterone. The natural progesterone is what keeps the placenta attached to the uterus. So mifepristone, when you give it, is essentially going to block that process so that the placenta and the uterus separate from each other. Mifepristone can also help stimulate uterine contractions. But there is another medication, the third one, misoprostol, which is a prostaglandin E1 agonist. This is the same medication that we use to induce labor when a woman is close to delivery. This directly stimulates uterine contractions and also causes softening of the cervix. So that together, mifepristone and misoprostol can be used to terminate a pregnancy in the first trimester. Systemic sclerosis, scleroderma, can involve many different organ systems: skin, gastrointestinal tract, the lungs, the vascular system. If you affect the vascular system, you can affect the kidneys, you can affect the heart. Let's go through some of these things over here. So, deposition of extra tissue fibrosis in all these different places, causing vascular dysfunction. Autoantibodies that you will find associated with it are anti-nuclear, anti-topoisomerase type 1, which is also known as anti-SCL70, or diffuse SSC. You can also find anti-centromere, which is limited SSC. Possible complications: interstitial lung disease, pulmonary arterial hypertension, myocardial fibrosis, pericarditis, pericardial effusion, hypertension, sclerodermal renal crisis, which is what I want to focus on here. In sclerodermal renal crisis, there is severe hypertension. I'm talking systolic up to the 200s. It looks like malignant hypertension. There's also signs of acute kidney injury, such as having an elevated blood urea nitrogen and creatinine. You can also have MAHA. What is MAHA? Do you remember? microangiopathic hemolytic anemia. All these things can happen suddenly in a patient with systemic sclerosis. So you have this patient come in, holy shit, their fucking blood pressure is through the roof. They have these clinical symptoms of high blood pressure, headache, blurry vision, all this stuff. You draw the labs, you see there's acute kidney injury going on. History. She may not give you a history of straight up severe scleroderma, but there may be some small things there, such as Raynaud phenomenon, gastroesophageal reflux disease, arthralgia, telangiectasias, digital ulcers, things like that. And this person, you know, they're having a sclerodermal renal crisis. So you have this patient with scleroderma that came in with a renal crisis. What do you do now? Their blood pressure's through the roof. Their afferent arterioles are clamping down. Well, what you're going to do is you're going to do something that you normally would not do in renal failure, or an acute kidney injury, I should say. You give an ACE inhibitor. The ACE inhibitor of choice that you use is captopril because it has a short time of onset. And so you want to do this because the renal crisis that they came in for was essentially induced by vasoconstriction, angiotensin-induced vasoconstriction responding to the fibrous deposition in the vascular wall of the arteries leading to the kidney. Kind of similar to the feedback process that we see in fibromuscular dysplasia. So you're going to give captopril, okay? Now, what do ACE inhibitors do? What do ACE inhibitors do to kidney function? They usually result in dilation of the efferent arterioles also, which decreases the GFR and causes an increase in creatinine. So you're going to see the same thing happen here. You give the captopril, it has a short time of onset. It is going to calm down the renal crisis, but in the process, creatinine will elevate. So just monitor that. Make sure it doesn't get too high. Address the blood pressure. Give something that is going to act quickly. Intravenous nitroprusside. Now, also need to monitor this as you're administering it, because a very sudden reduction in the blood pressure can also decrease renal perfusion. And this person already has a problem with renal perfusion. So if you decrease it even more, it can cause acute tubular necrosis. And if the kidneys are really fucked, they can get cyanide poisoning. Why? Nitroprusside has a cyanide group inside of it that needs to be eliminated by the kidneys. So we use it for a very short amount of time just to get the blood pressure into a manageable space where we can start to control it with other methods. And as the captopril takes effect. So you give both. Nitroprusside is going to act, lower the blood pressure. Then you start to titrate the dose down and wean it off as captopril comes on board and starts to do its thing.